I'm going to talk to you today about the management of open fractures. And in the treatment of open fractures, we've got three goals. One is to prevent infection, two, to restore function, and three is to achieve union. And these goals are interdependent, and that's obvious. What I'd like to get out of this lecture is to enable you to define and classify open fractures adequately, and this helps with your prognostication and your treatment plans, and hopefully you can achieve a rational treatment plan. Obviously, to start with, we've got to classify, and there are two classification systems you need to know about. They're both pretty similar, so I'm not going to dwell too long on them. The one that is used most commonly is the Castillo and Anderson classification system, and unfortunately, it's also the one that is most misinterpreted. So I just want to go through a few points. It's grade 1, 2, and 3, and the 3 is divided into an A, B, and C. And that's based on the size of the wound, the degree of contamination, the amount of soft tissue damage, and the bone injury, and that's often the forgotten part. So as you have a slightly bigger wound, slightly more contamination, so you'll go down in grading of your classification system. But just remember that you can have a 1 centimeter wound in a clean environment with a simple bone injury, and if there's a vascular injury involved that requires repair, this is going to be a grade 3C, and it's going to have to be treated in your management plans accordingly. So, as you know, I'm from South Africa. Next year, some of you will know it, we're holding we're privileged enough to hold the first African World Cup, Football World Cup, and I hope, how many of you are going to be traveling to visit it? Anybody? Yeah? Only 1, 2, 3. And if you're traveling to Africa, is it worth going to go on safari? Yes? Is anybody going to go on safari? Yeah, you're going to go? Okay, so you get a prize. Because when you go on safari, what they're going to do is they're going to actually tell you, the game ranger is going to say to you, you need that for the sun. Okay, so the game ranger is going to tell you that you only have a successful trip if you manage to see the big 5 in the wild, and that is the lion, the leopard, the buffalo, the rhinoceros, and the elephant. Okay, you all know that. That's called the big 5. So I'm going to introduce you now to the big 5 in open fracture management. That's treatment as an emergency, debridement, redebridement, stabilization of the fracture, and I have to say it again, the soft tissue, early closure, and the use of antibiotics. Before we go through each one of those, I'd like you to take your pens and just write down this list. And then after that, you're going to put your pens down and hopefully listen to the rest of this talk. 1, skilled resuscitation. 2, expert assessment. 3, operating room fast. 4, adequate debridement. 5, appropriate antibiotics and dressings. 6, stabilize fracture and soft tissues. And number 7 of this list is delayed closure, preferably within 72 hours. Okay, have you all written that down? You all? Yeah, okay. So put your pens down and let's just go through each one of the big 5 one by one. We'll start with treatment as an emergency. You've already been through the fact that you need to do your ATLS primary and secondary surveys, make sure your patient has a tetanus injection, and look at the status of the chest, the head, the cardiovascular system, and the general care. That's your general management. Then locally, do not expose the wounds unnecessarily in the operating room. There is an increased sepsis risk every time somebody goes and peeks to see what you have to deal with. Once you've seen the wound, if you're the treating surgeon, put on a simple saline dressing, align the limb, splint it, and get ready for surgery. You do not want to see this lying around waiting for x-rays. in your emergency room because it is going to increase risk of sepsis. And finally, distally, look at your neurovascular status. Number 2 of the big 5, debridement and redebridement. This requires a clinical assessment of tissue necrosis, and unfortunately that means it's highly subjective. Okay? And there are 2 discrete phases. One is wound irrigation, and the second one is removal of all necrotic and devitalized tissue, including the bone. We'll start with irrigation, and the solution to pollution is dilution. Gastillo said you must use 10 to 12 liters. This isn't an absolute value, but you must wash out with a lot of water. Either warm, sterile saline or simple tap water, if that's all that you have, is okay. Beware of using pressure systems because you may impregnate more debris further up into the soft tissues. Aim is to remove all the foreign tissue that you can find. Now, we have on your game drives, you may see some of these animals. This is the hyena and the silverback jackal. They're very good at debridement, but they don't know when to stop. So debridement isn't a science, it's more an art, and you're going to get experience with time as you go through your careers. You must go sequentially, starting with the skin, then you go to the fat and the fascia, then you look at the muscle, and then you go on to the bone. Beware, if you're using a tourniquet or if the blood pressure of the patient is low, you may misassess the muscle viability, so just keep that in mind if you have to use a tourniquet. And there must be no delay. If it happens in the middle of the night, take the patient to surgery in the middle of the night. The pitfalls are insufficient exposure, too cautious at debridement, and poor planning when it comes to salvage at a later stage with regards to flaps and exoskeletons and things which I'll discuss. Despite the meticulous initial debridement, it may be very difficult to determine the marginal tissue. So do a planned, scheduled redebridement in 48 to 72 hours and secondary wound closure at that stage. There have been some advances which have changed some of these things slightly. The one is our use of antibiotic bead pouches. The second one is the vacuum dressings. The third one is the new silver nanocrystal dressings. And, of course, the hydroscalpel, which some of you may have been exposed to and have experience with. I'd also like to speak to you a little bit about negative pressure wound therapy, the vacuum dressing, because it has changed my management of open wounds and of complicated wounds very positively. It is, in fact, a therapy, not a dressing. It promotes granulation, prevents colonization, and manages your exudate. And I use it almost routinely on all the open fractures that I can treat. You can get these very expensive units, and I'm sure most of you in Europe are exposed to this. And where I come from, the resources aren't always available, so we cannot apply this to just about everybody. But these are simple to apply and very effective. The systems give intermittent vacuum therapy, intermittent suction, which improves your granulation tissue by over 100%, according to the studies. But as I said, we don't always have it. So we make our own, and I'm going to show you how to do that. You need simple tubing, some opsites or tegaderms, some open cell foam, and it can be furniture-grade foam, and a vacuum system. And that's all you really need. The Granuflex seals help if you're using exoskeletons nearby. And what you do is you take the tubing and you cut some holes into it. You clean the skin around here so that you can stick your opsite down. You put a piece of foam down. You make a little tube of the cut end of the tubing. You make a sandwich with 2 pieces of foam like that. You stick it down with your tegaderms or opsites, making sure over here that you have a little umbilicus so that the tubing doesn't cause any pressure against the skin. You give the other end of the tubing to your anesthetist, get him to plug it into the suction system, and he switches it on, and that's the suck down that you see. It goes from there to there. When you see that, you know you're sucking. You want to go between 60 and 120 bar of pressure, not too much suction. And when you've got that going, this will give a continuous pressure system, which is about 67% improvement in your granulation tissue formation. But it manages the wounds very well, and I would advise you all to try it if you can. Yeah.
How much pressure would you do?
Between 60 and 120 bar. 60 and 120. Sorry, not bar. Yeah, millimeters. Yeah. We basically have high, medium, and low, and we put it usually between low and medium. This is an example of a case of mine that had about a 3 centimeter bone loss and a 3B open fracture. And she was treated in an external fixator. She had a wound like this, was being lined up for a latissimus dorsi flap. She refused, or she requested for us to try and avoid that. So we gave the option, and we put the vacuum dressing on. You change it every 4 days, so she had a number of surgical procedures, obviously, just to change of dressing. But that is the wound on day 5, and that is the wound on day 35. And that is, once she had got bone healing, what she'd been left with, which is quite significant. So I think that it's well worth trying. Anybody wants questions, please find me during the course and talk to me about it, and I'll show you what exposure. I've got more pictures that I can show as well. Number 3 of the big 5, stabilize the fracture in the soft tissue. You're going to hear about external fixation, and obviously most of this course is going to be about internal fixation. External fixation is fantastic, obviously, to utilize in the open fractures, but you must plan where you put your pins, especially if you're going to be doing flaps at a later stage. Consider whether you're using a damage control temporary external fixator or whether you're going to fix it to completion. You may want to use a slightly different construct, and again, you're going to actually have a practical on the different stability of constructs. And try and make sure that you understand, if you're using an external fixator, that you understand the mechanics of external fixation. If you're going to do internal fixation, it depends on the grade, the contamination, and the delay, and the nutritional and immune status of your patient. But certainly, yes, you can. Number 4 of the big 5, early closure. Primary closure must never be attempted, unless it is an articular component to the fracture. Don't be tempted to close those wounds primarily. Remember, you want to come back for a planned redebridement at 48 hours. That's when you must do your closure. So you do a delayed primary closure in all grade 1 and 2s and some grade 3 open fractures, or you go on for your split skin graft, your local or your free flaps according to the size of the wound. I'm lucky I can work in close cooperation with our plastic surgeons, and if you've got that, I think if you have plastic surgeons who you can work with, develop a good relationship with them because they can be very helpful. This is from the plastic surgical literature, and it's an old paper from 1986, but it's pretty valid because it's free flaps within 72 hours or over 72 hours. And just to summarize it, if you actually have a look, if you wait longer than 72 hours, there is a 10 times increase in infection rate. You double the time to union. You quadruple the time that the patient spends in hospital and the number of anesthetics that they have. So try and get definitive closure within 72 hours. This hasn't changed. And finally, number 5, the use of antibiotics. Well, that's been proven. Prophylactic antibiotics was been proven in a number of papers by Patsakis. There's a decrease, an 80% decrease in sepsis rate. Remember that open fractures are contaminated, so this is not therapeutic antibiotic treatment, it is prophylactic. So the questions really are, how do you give it? Which antibiotics? How long? Well, we give it IV usually, unless you use as well, you can augment with a bead pouch, which those that protect against staphylococcus and gram-negatives, and we have a protocol in our hospital that all grade 3s will get triple antibiotics. I'm sure you'll have similar protocols in your hospital. And for how long? Difficult to say, but controversial. 24 to 48 hours is what the books will tell you if you look at the different literature. And really what I'd like to say, actually keep your patients on antibiotics until you've got decent skin cover of some sort. And this is actually something that must be dealt with in proportion to the severity of the injury. So, in conclusion, this is what you wrote down in the beginning. You want skilled resuscitation, expert assessment. You want to get your patients to the operating room fast. You want adequate debridement, the appropriate antibiotics, and the appropriate dressing. You want to stabilize both the fracture and the soft tissue, and, if possible, get delayed closure within 72 hours. And if you remember the big 5 of your safari, that I hope more of you are going to go on sometime next year, you will remember the big 5 of open fracture management, treat as an emergency, debridement, stabilization, early closure, and the use of antibiotics.